My name is Jorge Nieva, and I'm here at the 2024 World Congress on Lung Cancer. I work at the University of Southern California Norris Comprehensive Cancer Center. And I'm presenting a poster tomorrow on real-world evidence with osimertinib in uncommon mutations. We all know that osimertinib is a great drug for patients with deletion 19 mutations in EGFR, as well as the L858R mutation in exon 18. However, there are a lot of other EGFR mutations. And the question is, what is it like and what outcome should we expect with osimertinib in that patient population? Now, one of the great things about real-world evidence is it gives us an opportunity to see data without the expense of conducting clinical trials in a prospective manner. And it also gives us access to data from many more patients. So we analyzed the Flatiron database and looked for patients treated in the United States with osimertinib who had some of these less common mutations, things like G719S mutations and S797 mutations. And the interesting thing that came out of this work is that many patients, of course, we know have more than one mutation. And while some patients have common mutations, canonical mutations, the exon 19 and L858R mutations, some people have those mixed with the uncommon mutations. And some people have uncommon mutations by themselves without the presence of the more common canonical mutations. And what we found was the outcomes with osimertinib were actually different and much better if the patients had both a common and uncommon mutation than if they had an uncommon mutation all by itself. And so while osimertinib can be used for patients who have uncommon mutations alone or these compound, common and uncommon mutations, we find that the patient outcomes are actually much better when they have both mutations. So there are many drugs that can be used for people with uncommon mutations. Osimertinib is one of the drugs, but there are other drugs such as afatinib, which is approved and can also be used. And so people may want to look at this real-world evidence and use it to try to decide what's best for their patient and may look at whether their patient's mutation is a sole uncommon mutation or whether it's one of these compound mutations where we see both types of mutations present. I think there's going to be differences in the physical biology when the EGFR molecule has more than one mutation. We know from a paper that came out years ago from Jacqueline Robichaud and John Hymak's group at MD Anderson that certain mutations of these uncommon mutations, they are C-loop compressing mutations. And in those mutations, you seem to get preferential binding for afatinib over osimertinib. However, when you have compound mutations, it has different effects on the structure of the molecule, and that may be impacting binding. That's just one hypothesis of what may be happening. It's also possible that each individual cancer cell may have one mutation or the other, and the osimertinib is working on a subpopulation of cancer cells better than on the other population of cancer cells. But when we detect these mutations, what's most likely happening is the patient actually does in fact have both, much like we commonly see with the T790M mutation. And I think these sort of complex effects on structural biology do impact binding of drugs and is going to impact drug efficacy. I think more studies with real-world evidence are going to be very important for us to better understand the outcomes of patients who are treated in the real world. The real world has no exclusion criteria, much like clinical trials do. And so really to get a good sense of what's happening to patients who don't fit the narrow inclusion and exclusion criteria of clinical trials, real-world evidence studies provide us with that sort of snapshot of what happens in a much more varied population.